Hey Rebels, welcome to Rebelcast, your go-to source for the latest in knowledge translation of medical research and all things emergency medicine and critical care. Marco Propersi here, thanks for tuning in. Be sure to subscribe to the podcast and follow the team on social media to keep up with the latest content. Today, we're talking about a potential game changer in the ER. It's a revolutionary AI tool for EKG interpretation, the Queen of Hearts AI model, and it's already changing the game in detecting occlusive myocardial infarctions on EKG. If you're ready to learn about AI and the impact it's making in the ED, keep listening. My co-host today is Dr. Joe Bove. He helped me critically appraise the paper and co-authored the Rebel post. Joe, tell the world something they don't know about you.
Hi, Rebels. How's it going there? So I'm Joe Bove, currently faculty at St. Joseph's in Patterson and Wayne. I'm very passionate about emergency cardiology and EKGs, like our gurus that are on with us today. I oversee the STEMIs that come through the doors of our department, as well as host EKG nights with our residents. Do have to give a shout out to our amazing residents. And I'm looking forward to the deep dive today.
We have Steve Smith. Dr. Myers, tell the world something they don't already know about you.
Hi there. Well, I'm Pendell Meyers. I'm an assistant professor of emergency medicine here at CMC in North Carolina. Something that people don't know about me, maybe not everybody knows how long I've been bothering Steve about all of this, how long I've been stalking him for knowledge. It must have been back in 2011 or 2012, Steve, that I first started bothering you about this and basically just kept sending cases and trying to get your teaching this stuff until it became clear that I wouldn't go away. And so we started doing research together. Now it's been 12 years of this. And I'm really excited to talk about what we've done and what's happening now.
All right, thanks for that intro, Pendell. And Dr. Smith, you're up. Say hello to the Rebels out there.
Hello, Rebels. Well, I've been fascinated with EKGs since I was a resident, starting about 1988. So you know now that I'm a very old man. And I got fascinated in it because we had to give thrombolytics back then. We had to be right about who we were giving it to and who we were withholding it from. And so I decided to give a lecture on it, and I got more and more into it. And I wrote a book called The ECG in Acute MI in 2002. And then in 2008, I started Dr. Smith's ECG blog. And in 2012 or 11, as Pendell said, he contacted me. And I realized that this guy who had not even started medical school could read an EKG better than any one of the faculty in our department. So we started doing research together, and wasn't long before he finished. He went into medicine, graduated in 2016, did emergency medicine, and we were working together the whole time there. And maybe also you don't know that up until 2014, I'd been giving a talk called "Non-STEMI That Need the Cath Lab Now," and then I realized the STEMI non-STEMI dichotomy has just got to go away. So I started talking on the false STEMI non-STEMI dichotomy, and then in 2018, Pendell said, we just got to rename it. So let's just rename it. And we did a Twitter poll. Should we call it acute coronary occlusion myocardial infarction, ACOMI, or should we just shorten it to OMI? And people on Twitter overwhelmingly thought we should call it OMI for OMI NOMI. And that's where it all began.
There was no votes for the Pendell Myers or the Steve Smith EKG paradigm. That's a perfect segue. We were going to do an introduction and talk about some of the cath lab activation criteria. And I think most facilities are still using our STEMI criteria. And this is outdated because it misses a lot of these subtle EKG findings that you both talk about in your OMI manifesto. Help us understand the difference between STEMI and non-STEMI and OMI and NOMI.
Sure. So STEMI just simply is a definition that means that it meets the fourth universal definition of myocardial infarction, and it has STEMI criteria. The patient has STEMI criteria. That's all it is, pure and simple. OMI is something quite different. OMI is the actual underlying disease, the underlying pathology that you're actually trying to find when you are in front of that chest pain or chest pain equivalent patient. OMI conceptually is defined as acute coronary occlusion or near occlusion without collateral circulation, such that there will be imminent full thickness myocardial infarction without any reperfusion therapy if we don't provide that reperfusion therapy. So STEMI, in a way, is just a very, very crude tool at finding the thing that you're actually looking for. all of the mechanism of benefit of all reperfusion therapies we offer completely centers around improving flow through an acutely occluded coronary artery. That's the only mechanism of benefit for all the things we do, PCI and thrombolytics, everything else. And so those are the patients who we think benefit from those therapies. It just turns out that STEMI criteria, definition of STEMI versus NSTEMI, is not a good way to find them. So this is a different organization of the disease of ACS, of the high end of the disease of ACS. We don't think that people should look for STEMIs versus NSTEMIs because what they really are looking for is OMI versus NOMI. Steve, what do you have to add to that?
Yeah, well, people have believed for years that ST elevation means the artery is occluded, and lack of ST elevation means the artery is not occluded. And that comes from data back in the 1980s that is extremely poor quality. I won't go into the details of that. It is ridiculous that we're depending on this data from the 1980s, which is terrible. And the other thing is, believe it or not, there have only been 3 studies in all of history that looked at the ST elevation criteria, how good it is at diagnosing acute coronary occlusion. It's supposed to be the gold standard for diagnosing acute coronary occlusion. And in these 3 studies, a recent meta-analysis showed that the sensitivity is 43%. And that goes along with all of our data as well. So you're missing over half of acute coronary occlusions if you rely on ST elevation millimeter criteria. Now, I will add that there are some places we see lots of data sets, Pendell and I, and we've seen some places where they call STEMI anything that they take to the cath lab quickly, whether it meets STEMI criteria or not. And so the data on it is all mixed up and very heterogeneous. So you'll get somebody who says, oh, we find that we don't have any non-STEMIs that have occlusions. And you look into their data and you realize they don't use the STEMI millimeter criteria. If those places that do believe the guidelines, which insist on STEMI millimeter criteria, those places are missing over half of their occlusions.
Yeah, I really like the idea that it's almost like a cognitive reframe, right? Instead of just using this very specific diagnostic criteria, it changes it into, can I actually help the patient? What is at risk on this patient, right? Myocardial death. And I think before that, by strict adherence to the STEMI criteria, it's like, okay, no STEMI, there's nothing for me to do. I'm just going to park this patient on a heparin drip and let somebody figure it out in the morning. And now that we have more objective tool, or a tool that finds very subtle but still equally objective findings, it gives you some ammunition when you're calling the cardiologist in the middle of the night. And it's like, no, this person needs to go. It gives you something to fight for. And I think most docs who are working at the bedside and in our communities and our rural places, this is a tool that's going to allow them to fight that battle and do something for their patients. But let's move on a bit, because I think this is where the Queen of Hearts model steps in. And both of you, and I think you had a team with you, developed a Queen of Hearts AI tool, and it has the amazing potential to spot some of these subtle signs on OMI versus STEMI that we might not otherwise see. Now, give us some background. What went into the development of the Queen of Hearts AI model?
Yeah, we have an excellent team. This is all kinds of different people that come together to make this. Steve and I give the clinical and sort of EKG knowledge side of this. This is a really big team, including data scientists, AI engineers, regulatory experts, all kinds of people that Steve and I could not do this without. So it's a multidisciplinary team that has access to very good data. I'm not the one who literally can code this and create this algorithm, this AI model, but I like to think of it pretty simply as you give the computer all of the data that you want to optimize to find the thing that you're actually looking for, which is patients who have acute coronary occlusion or near occlusion and suffer big, bad heart attacks from it. And then you let the computer learn and memorize and distinguish anything that it has the ability to on that EKG to best predict patients in the future who have the outcome that you want. So rather than the gold standard being some cardiologist writes the word STEMI or NSTEMI on the chart, this is the patient's actual outcome that we're titrating towards. So that's what the AI model is designed to do. And it takes a whole team of people to make that happen. And that's what we did.
And so we don't give the system any instructions. We don't say, look at the size of the T wave, or look at how much ST elevation there is, or how big is the QRS. Those are all important features, But all we say is we tell it that this EKG represents OMI or this EKG does not represent OMI. And we determine that based on our reading of the EKG, along with all kinds of outcome data, angiography, troponins, echocardiography, serial EKGs. In every case, Pendell and I go over in detail and then code that each EKG as to what the state of the artery is, the time of each EKG. And we just give that to the AI system. The AI system gets OMI or not OMI and sees tens of thousands of EKGs and then is able to find the features that make the diagnosis. And it turns out that the version 1, which was, we're now on to version 2, but version 1 was exactly as good as I am.
Yeah, I think what's most interesting about this is that you guys have found a definition or an endpoint for OMI that is very realistic and accurate. And so I think if you can discuss why you feel like your endpoint for OMI is the best or, is the most specific endpoint, then I think we can better understand why your AI model is so good.
So Steve, let's talk about how difficult it is to come up with an endpoint that works for all parties in this huge equation. It's very difficult. And I want to give you the limits, like the upper and lower limit of this definition, because you'll see in different papers, we've used different definitions. And this is because it's impossible to please everybody with one outcome definition. And the outcome information that we have doesn't always tell you what was happening at all of the EKGs before the actual moment of that angiogram. This is a super dynamic disease, and the state of the artery when the patient shows up to the ED is frequently not the same looking artery as the artery during the cath lab, even just 30 minutes later, as fast as you can have it done. So how do you make an outcome that relies on the angiogram at the time of the angiogram, but doesn't tell you any information about all the time other than the angiogram? Very, very complicated. So, Steve, do you want to tell them about kind of the rates of open arteries, even for STEMIs?
Yeah. So if you take patients who everyone would say is having a STEMI, no controversy, they go to the cath lab, 33% of them have an open artery. In fact, 20% of them have what's called TIMI 3 flow, which is perfect flow through the coronary artery. How could that be? That's because acute coronary syndrome is the formation of a thrombus in the coronary artery. Everybody knows that we have our own endogenous TPA, and thrombi propagate and lyse and propagate and lyse, and they're constantly doing that. In fact, there have been people who've looked at coronary arteries with angioscopy during acute coronary syndrome, and they've witnessed thrombi propagating and lysing. So you get an EKG at time 0 when the patient's having chest pain, and it shows a massive STEMI, or maybe it only shows a subtle OMI. The artery is occluded at that time. You get to the angiogram, artery's open. Now, if I do that with a massive STEMI and we get to the cath lab and the artery's open, they say, well, that's just because the artery opened since you got the EKG. But if I show them a subtle EKG, which they don't believe that is really an occlusion myocardial infarction, and I go to the cath lab and the artery's open, they say, see, the artery wasn't closed. So they hold subtle OMI and obvious OMI to a different standard. One to a higher standard, the one they believe in, and one to a lower standard. And so I've known this for 25 years, this problem. And my very first study was on left bone branch block with Smith modified Sgarbossa criteria. And in order to have an outcome criteria for that, I insisted on there being TIMI 0 to 1 flow or TIMI 2 or 3 flow, pretty good flow, plus a very high peak troponin. Why a very high peak troponin? Because at that time, there were several papers showing that most STEMI have a contemporary or fourth generation troponin I above 10 nanograms per milliliter, and most non-STEMI below. Not all, there was some heterogeneity there, but that's because if your artery is closed, completely closed for a sufficient period of time without collateral circulation, you generally will end up with a large infarct. And peak troponin is a pretty good measure of infarct size. So I would say, okay, I'm going to have my outcome be either the artery is closed or there's a culprit that we intervene on and a very large MI. So I still think that's the best outcome we can do until we get an EKG measured at the time of the angiogram. But you send those papers to cardiologists and they look at it and they say, what do you mean this isn't OMI? How could you call it occlusion when the artery is open. So this is a major problem in the research.
I want to bring it back to your question. So you'll see different versions of the OMI outcome definition in different papers. And I would say the loosest version of what we have published is probably the paper that we're reviewing now, which is culprit TIMI 0 to 1 or TIMI 2 to 3 with urgent PCI. So that's kind of the lower limit of the loosest definition of OMI that you'll see in our papers. And then it goes all the way up to the tightest definition where we require a culprit which still has TIMI 0 to 1 flow, even at the time of delayed angiogram. So,
Or even TIMI 0 flow.
yeah, even TIMI 0 flow. So having said that, you can see all our different definitions in different papers, but in every paper, we always show you a table with all of the definitions. So having said that there's, many different versions, every single version you look at, we always win with OMI. So for example, all of these definitions here, and I'm looking at table 3 in our paper, 130, every definition at the same specificity, we have about double the sensitivity compared to the STEMI criteria. So as long as you compare it to current practice for STEMI criteria, any of these versions of the definition of OMI is totally fine by me because they all have weaknesses and advantages for describing the actual disease, and they're very difficult to make everybody happy. But we just, we perform better on any definition that you want to talk about.
This is a great segue to the results. If you guys can share your thoughts on the results section, particularly if you thought that there were any surprises along the way.
The AI model was able to find these OMI patients an average of 2 hours faster than the STEMI criteria. So meaning, even if you're a person who develops STEMI criteria on your serial ECGs, the Queen of Hearts of the AI model was able to detect that patient 2 hours earlier on average by using earlier ECG findings of OMI.
I can't beat the drum enough for the AI model. When I read this paper and I'm like, this is amazing. I mean, this is still just stickers on the chest, right? So to have something that's this sensitive, one of the things we said is it turns every single medical student into Pendell Meyers and Steve Smith. So it's kind of funny.
The other thing about it that is fantastic. So when we've presented this at International Society of Computers and Electrocardiology, they're like, this is impossible. What this algorithm does is it turns any image into a digitized ECG image. Now, you have to understand that EKG machines record 10 seconds of each lead. All right. And then they print out a print which has 2.5 seconds of each of the 12 leads. Right. And that is in an image, or it's a JPEG file, a PNG file. It's recorded on the EKG machine as an XML file. And the XML file is the only thing that AI can deal with. So every other AI system in 12 lead EKGs takes the original recorded digital file, which is 10 seconds of each lead in XML, and analyzes it. And for AI to analyze it, to go backwards, to take a JPEG, for instance, image, you can't analyze it with AI. And everyone at this conference said it is impossible to digitize an image such that AI can use it. But Powerful Medical, the ones who we work with to make the Queen of Hearts, they create an algorithm that can digitize any EKG. So you have paper EKG, even if it's crumpled up and written all over, all you take out the app, you take a photo of it, and it instantly digitizes it, which everyone said was impossible. And then it analyzes it.
Now, Stephen Pendell, we always have to consider the limitations in every single paper. The 2 data sets you used for derivation and external validation had a very high incidence of patients with acute coronary syndrome. Now, how do you see, or do you see, the Queen of Hearts performing in a screening capacity similar to how EKGs are done in the emergency department, like in a triage capacity? Do you see it functioning well? And do you have plans for that type of research in the future?
I would say that we came to a specificity of 97.7% at a sensitivity of 68%. And most of the algorithms that are in use now have a specificity of 98%. So the specificity is the same as it is for the conventional algorithms. Now, a lot of people are frustrated by the conventional algorithms because they'll see STEMI on there when it's obviously not a STEMI. So we did it on a group with a high incidence of ACS. And so the problem then is specificity. If you're screening everybody who comes in with chest pain, then you need to have very high specificity in order not to have too many false positives. And so that Will we end up with too many false positives? Well, we have a prospective study that is already going on in Belgium, and they screen every patient with chest pain with Queen of Hearts, and they doubled their sensitivity for occlusion using it, and they only had 6 false positives in a 3-month period. And all 4 of the false positives were people who had a recent myocardial infarction, and 2 of them were, one I think was Takotsubo and one was myocarditis. So it was, the false positives were not a problem. And this is a place that is using it already on every ED patient with chest pain. That was presented at the American Heart Association just last week.
Yeah, that's pretty amazing. I mean, I can't wait to see some of these prospective trials as they come out because I have no doubt it's going to be super impressive.
A little bit to add to that. So, while it's true that the training data usually has a higher prevalence of OMI than the disease, we're still able to account for that when we make models. So the models are designed with the idea of a prevalence of about 1 or 1.5%. I can't remember the last one that we used, but we're very keenly aware that the way that the model will be used is not only on patients who you already are very certain has the disease. So all of the models are made with that in mind because we know this is going to be applied to a lower prevalence of disease than 20% of OMI is I believe, the rate of OMI in this particular we're reviewing. And also we have some recent data using our updated models. We have some all-comer level data with OMI percents and the 1 or 3% range. We have some European data from Germany that is being submitted soon. In that data, we actually have some metrics where we look at the amount of false positives compared to the STEMI criteria. And we have subsets of the false positives that are totally negative troponins, meaning people that don't even have MI at all. It's one thing if you have an MI, that's a small MI is a better false positive person who has chest wall pain and 0 troponins, right? So in our new studies with our new model, we actually have less false positives than STEMI criteria. Less false positives, including people that go to the cath lab, and less false positives of people that completely rule out by myocardial infarction. So as this gets better and better, I don't think that it will even be that much of a trade-off, honestly, especially compared to the STEMI criteria. I think we will have a better recognition of true OMIs, and I think we will also have less false positives overall.
So there was another study from St. Louis University that was presented at AHA, and it was all chest pains that came to the ED in October 2023. The outcome for OMI was TIMI 02 flow or TIMI 3 with a very high troponin. So the 528 consecutive patients, and 498 were ruled out for MI, 31 underwent angiography. 518 of the 528 did not have OMI, 10 did have OMI. Cardiologists had 6 false negatives and 3 false positives. Queen of Hearts had only 3 false negatives. It had 4 false positives, which was 1 more than the cardiologist, but the cardiologist false positives, none of them had culprits. And the Queen false positives, all of them had culprits, but they didn't meet the criteria of a very high troponin. So the Queen of Hearts was far better than the cardiologist. This is a consecutive 528 patients where only 10 of them had an OMI. So fewer false positives than cardiologists.
And more meaningful false positives.
And more meaningful false positives, right?
Exactly. And Steve points out that we have prospective ongoing implementation trials in the United States of this technology. So it's very exciting to see this play out.
Yeah, pretty amazing. I mean, this is what Marco and I have been talking about, is that this technology could eventually be used in a screening capacity. And you're getting a glimpse of that through you guys right now with the data you're sharing.
Let me tell you about another paper I'm writing right now. Over the years, I've collected many, many cases of what conventional computer algorithm called a totally normal EKG. Now, there have been 3 papers written so far that purport to conclude that if the conventional algorithm says the EKG is totally normal, that the triage physician doesn't even need to look at the EKG. You're probably aware of those papers. Well, we've collected 60 cases where I could recognize OMI on the EKG. The outcome indeed was OMI, and the computer algorithm said it was completely normal. Now, it turns out that 18 of those 60 cases we used to train the Queen. So we excluded those 18 cases and we had 42 left. Put them through the Queen of Hearts. Queen of Hearts diagnosed OMI on 80% of the cases. The conventional algorithm didn't call it non-specific STT or anything. It called it completely normal. And the Queen of Hearts called it OMI, 80%.
One of the EKG manifestations that tends to get a lot of buzz in the emergency literature is ST elevation and AVR with diffuse ST depressions, which we know has been on your blog a number of times. That scenario really requires some clinical gestalt sometimes, can be anemia, can have a pretty large differential. Can you take us through how the AI model would approach that type of rhythm, being that doesn't always weigh out in the end to represent an OMI?
A lot of this relies on the physician using it on the correct patient population. You're totally correct that it is so easy for any sick patient to have subendocardial ischemia from a variety of reasons. And subendocardial ischemia, by any cause, whether it's ACS or the vast majority which are not ACS, does produce ST elevation and AVR and diffuse depressions. So especially in like version 1 of the AI model, you really need to be careful to use it on the appropriate patient population. We don't have any training in our models for like patients who are sick otherwise, with sepsis or GI bleed or hypotensive or hypoxemia, respiratory failure. A lot of those patients have ST elevation and AVR and has nothing to do with ACS. So step 1 is this is an AI model that's designed for EKGs with ACS patients. And so you will have to be the arbiter of who to use it on, and that will help a lot. If you use the models in the correct patient population who have a significant chance of ACS, then it's really even a different question, because often, patients with ongoing ischemia, ongoing pain, and ischemia on the EKG from ACS, that has to go to the cath lab, no matter whether it's a full occlusion or not, or matter whether it's STEMI or NSTEMI. All guidelines in the world say that those patients should go to the cath lab anyways. So then the question is, what does the model actually say about an EKG like this? And that's something we're still learning about. Version 1 seems to confuse subendocardial ischemia patterns with OMI a bit more than other difficult EKG patterns. Maybe that's teaching us something. Maybe that means that some patients with OMI who have some little collateral circulation somewhere else produce this. The nice part that I can tell you now is future models will have a better way to handle this. So right now we're working on a multi-output model, meaning it doesn't just have to say yes or no binary. It will say essentially yes or no to the following 3 things: active OMI, reperfused OMI, or subendocardial ischemia. And this one that you're talking about, ST elevation AVR with diffuse depressions everywhere, that is subendocardial ischemia, according to Steve and I. That's how we talk about it. And so if you use it in the correct patient population who you think has ACS, and it says subendocardial ischemia, then the patient, unless they immediately resolve all their symptoms and EKG findings right in front of you, should be a candidate for emergent reperfusion therapy, especially PCI for now. Lytics will be a little bit more challenging conversation, but that's how I think about subendocardial ischemia, and that's how our models are soon going to be able to describe it discreetly.
Yeah, I would just say that the EKG you can diagnose subendocardial ischemia on the EKG, but you can't say why there is subendocardial ischemia. And so the first job of the physician is to figure out, is this clinical presentation consistent with ACS or consistent with something else? And it's consistent with ACS, then subendocardial ischemia is likely to be due to acute coronary syndrome, not occlusion, very unlikely to be full occlusion. It's usually subtotal occlusion causing insufficient flow, but not completely blocked flow. There was a study published at the University of Arizona in AGEM not too long ago where they looked at the outcome of occlusion in patients with this pattern of diffuse ST depression and ST elevation AVR. Only 10% of patients had a coronary occlusion, very few had ACS, and that's because the vast majority have sepsis, pulmonary embolism, GI bleed, severe dehydration, that sort of stuff, shock, respiratory failure.
Yeah, makes sense. Thank you for clearing that up, because that's definitely a finding that we see very often in the emergency department. And definitely curious to see how the AI model approached that, but certainly requires some clinical gestalt, applying it to the right patient population. Talking about another EKG manifestation or perhaps arrhythmias, AFib and wide QRS rhythms came up in the paper. I hate to use the word struggle because we felt the AI model did a great job in all rhythms, but I would say it struggled compared to other EKG manifestations. Why do you think these specific rhythms posed a challenge, perhaps for the AI model? And would it be helpful if the AI model incorporated old EKGs, particularly in these complex cases where it may have needed the comparison?
I would expect it to do a, a worse job in atrial fibrillation until it gets more training, because people with atrial fibrillation have a lot of ST depression that is not due to thrombotic disease or ACS. And it's frequently confused by human interpreters, especially, for instance, you can have an EKG that looks like posterior MI, but if the patient has atrial fibrillation, it is not a posterior MI until you get them out of atrial fibrillation and re-record, because for some reason, which I don't understand, the ST segments in atrial fibrillation mimic a posterior OMI. So there's lots of ST patterns that can mimic OMI in atrial fibrillation. And as for left bundle branch block, we just didn't have enough cases to train it with, really, with clear, definite outcomes. So until we get enough cases of left bundle branch block and also ventricular pacemaker to train it with, it's not going to be as good as it is with normal conduction.
Yeah, I would just say in general, the wider the QRS is, the less common it is to be able to find cases that have OMI in that complex. And so the harder it is to train. I think Steve may disagree with me, but I would say I think my accuracy gets lower the wider the QRS is. I think I have less accuracy in left bundle than I do for normal complexes, and the same goes for ventricular pace rhythm. It's my opinion that the EKG is just a little bit harder, even knowing the modified Scarbosa rules and all that. I think that EKG is just not quite as good for finding OMI as it is in normal QRS.
I would agree with that.
And what about incorporating some of these old EKGs, particularly in AFib or wide rhythms or left bundles? Would that make any difference?
We would love for the Queen of Hearts to compare with baseline EKGs and do serial EKGs, and that's in the long-term plan. The moment that's a big project, and it will happen eventually.
I mean, it's amazing right now that it's doing without clinical gestalt, without old EKGs, and the data is this impressive. So, all right, let's segue into the competition and the other AI models that are out there. There's definitely a growing body of literature out there on multiple different AI models, including the Queen of Hearts. How does yours differentiate yourself from some of the other AI models that we can see some papers coming out on?
When I look at all the other papers on AI, first of all, their title usually says STEMI, and I can't tell what they're using as an outcome. They don't specify. They say, our outcome was whether the patient had a STEMI or not. I'm like, what's here? How are you defining a STEMI? And they act as if everyone knows what a STEMI is, but not everyone knows what a STEMI is. Some people call an OMI a STEMI. Maybe they're using OMI as an outcome, but they don't say how they're defining OMI. Or maybe they're actually using ST elevation millimeter criteria as their outcome. I don't know when I read those papers, and none of them specify. Now, there is one other algorithm out there that you can try yourself called ECG Buddy. It's from South Korea, and it does a pretty good job, actually, but there's no papers on it that I can find, although there are papers on STEMI from South Korea, and I can't figure out if the papers from STEMI in South Korea are using the ECG Buddy as their model or not. What do you have to add there, Pendell?
Although there's a lot of AI looking into EKGs and cardiology, the vast majority of it is all about rhythm stuff and detecting AFib and wearables and outpatient populations. Steve and I are really only aware of our model and then ECG Buddy and the one from, was it Pittsburgh, Steve? Or which one?
Yeah, the Al-Zaiti one that was published in Nature Medicine, on which I was a co-author, actually. And that I don't know if you've read that paper. If you have, it is very deceiving. They use their sensitivity in patients with a high heart score and use their specificity on a cohort with a low heart score. They don't calculate their sensitivity and specificity on exactly the same population, which is not fair. What you can do when you're looking at their paper, though, is look at their ROC curve, and you can see that basically when the sensitivity matches specificity, it's 88% each. That's considerably lower than ours, much lower. I mean, we have 91%, at 98% specificity, we have 91% sensitivity. They had 88 and 88. The other thing is you can't use their algorithm. It's not available. Nobody can test it out and see how they like it. So even I can't, and I was a co-author on the manuscript. So
I know Joe and I are about to review a paper. Is that the South Korean paper? I think that's
Yeah.
the next one we're taking a look at. So stay tuned for that. Pendell and Steve, I just want to move forward a little bit into the future. We polled some of our friends, we polled some of the audience, and some questions came up. Do you have plans for the future into, I guess, putting the Queen of Hearts into perhaps like an EKG machine where the interpretation is already on there, or perhaps even in the EMR?
Well, a lot of that's not really up to me and Steve, and we're sort of don't have all the plans for what's going to happen there. And I just don't know what the future will look like. Will it be bought by Philips and then and Philips machines and not other machines? Steve and I really don't have a lot of control or awareness of part of this. We just want to make it as best as it can. So I really hope so. I hope it's used by anybody that would let us use it. I would say one possible future would be that this plays out in a similar way that other companies like Rapid AI and Viz AI played out. So these are independent companies that do the same thing that we're doing for stroke. They look at the CT angiogram and they notify the hub and spoke models of who has the acute large vessel occlusion. By the way, what a great wording for a disease of arterial occlusions, right? They find the patient that has the large vessel occlusion, and then they AI interpret the CT angio to find it, and they notify the interventionalist who's at the spoke, the hub center, who's the one who's going to fix it, transfer the patient. It happens as rapidly as possible, and it's all, AI learning how to read the CT angiogram for occlusion. So I think it's possible that this company could play out in a similar way as those, and become kind of not particularly affiliated with a machine, not particularly affiliated with a certain EMR, but kind of in that model that Rapid AI has.
I think it will be available to everyone in one form or another.
That brings me to my next question. Do you think that there's going to be some attrition of skill? And I guess the two follow-up questions will be, how do you think it'll affect ED physicians and actually for medical education, medical students? I mean, is there going to be another Pendell Myers and Steve Smith in 10 or 15 years?
I don't think there's hardly any skill right now. Anyway, I mean, the expertise out there at reading subtle EKGs is about nil. Even obvious ones are missed all the time. And the best way to learn is to get instant feedback. So you're looking at your EKG, you go, what's going on there? And then Queen of Hearts comes in, boom, and tells you this is an OMI. And then she gives explainability too, which we haven't talked about. There's an explainability map. You can see exactly what she sees on it. The T wave, the QRS, the ST segment. And you're like, oh, look at what she saw there. And this lead, she says it's high confidence. And this lead, she says low confidence. And that's a far better way of learning than any other.
I will agree. I don't think there's a lot of skill to lose, and that's not the clinician's fault. That's not emergency medicine's fault. That's not cardiologist's fault, by and large. They have been trained that the actual disease that they're looking for is literally defined by looking at millimeters and seeing if two leads have X number of millimeters. That is the training. Like we have STEMI equivalents, but that hasn't really done very well in the past 10 years of having STEMI equivalents. Nobody researches them except Steve and I, in our group of 10 or 20 people. There's just not that much skill to learn because the current definition of this disease has people so brainwashed and has their level of skill and training so restricted to the STEMI criteria that they just haven't learned it yet. And I think that AI and the explainability images that we're putting out is a really great way to teach. Steve and I can talk about, how bulky that T wave is. It's barely hyperacute, but when you see the AI light it up with blue and say, this is the reason that this EKG matches 20,000 OMI patients that I've learned about in my training, that's powerful. And that has a level of inter-rater reliability that is so much more consistent than just Steve and I's opinion.
Yeah, what other disease is named for its test? Is there any other? I can't think of any other. I always say, that's calling appendicitis a high white count abdominal pain. If the white count's not high, it's not appendicitis, period, because we're defining it by the test. And then you say, well, we discharged the patient with a low white count abdominal pain, and we did the surgery 2 days late after it ruptured, but that's okay because it had a low white count and it wasn't a high white count abdominal pain. Therefore, we didn't need to be treated quickly. That's exactly the same thing. And this brings up the no false negative paradox, which we haven't brought up yet, which Pendell coined term, and I think it's brilliant because you can't have a false negative test in the STEMI paradigm. If there's not ST elevation and there is occlusion, it's not a false negative because it's a non-STEMI. Therefore, it wasn't a STEMI, therefore it can't be a false negative. And so that means that when it comes to quality assurance, no one reviews the cases of missed occlusions because they didn't miss anything. They didn't miss a STEMI, so they couldn't miss anything, right? We're biologists, right? All doctors are biologists. What in biology follows millimeter cutoffs? Imagine how stupid that is when you think about biology, how complex biology is. And so it always reminds me that one cardiologist, it was a colleague of mine years ago, he said, I don't know what the big deal is. Either there is ST elevation or there isn't. And I was like, oh my God, this is a biologist,
I heard one cardiologist joke that they rely on the oculomotor reflex, which is like the eye, right? So it's they either say it's there or they say it's not. But
yeah.
Joe and I talk about that same thing all the time. It's like they can't be wrong from a quality perspective, right? It's like if they say it's not, then it's not.
It's not. Well, Pendell and I have some great data which Pendell's been analyzing, which shows that the most important variable to whether a patient gets diagnosed with a STEMI or non-STEMI, whether the artery is occluded or not, is whether they met the door to balloon time criteria. And if they didn't meet the door to balloon time criteria, they'll just call it a non-STEMI. And then they got good reviews,
That's why, to me, the most important thing that we discussed was the OMI, the definition and the endpoint of OMI, because really that's really the crux of it. The subjective nature of a cardiologist calling one of these disease manifestations a STEMI is so subjective, really, at most shops.
All right, Dr. Smith and Dr. Myers, is there anything you guys want to talk about that we haven't hit on already?
I would just say that it's incredible how this test has been around for over 100 years is so poorly understood by all physicians. And how little really important findings are missed on this incredibly common and easy test. And it's perfect subject for artificial intelligence. It is a perfect case used for artificial intelligence. And that's what I've been saying for 10 years. I've been looking for some company whose system I could teach artificial intelligence to. I worked with cardiologs in Paris since 2014. They contacted me. They wanted me to work with them. I did. I published several papers with them, but I kept on pleading with them to work on OMI rather than working on atrial fibrillation. But they thought atrial fibrillation was so important. I thought OMI was so important because so many lives can be saved. Tens of thousands of lives in America could be saved every year if their acute coronary occlusion was diagnosed immediately and they opened up immediately. Anyway, cardiologs didn't believe me. Finally, Power for Medical found me and Pendell, and we've been working with them. And this is going to revolutionize care of acute myocardial infarction.
Pendell, Steve, I guess last question I have for you is a pretty simple one. When do you think this will be available widely in the United States?
All depends on the FDA.
Okay.
So maybe it depends on RFK. I don't know.
Well, with that, we'll say, listen, folks, we have an international audience. Some of you may already be using the Queen of Hearts. And for those of you in the United States, stay tuned. Keep on the lookout for the Queen of Hearts AI model. It truly is amazing. And that wraps up today's episode. Stay tuned as we continue exploring cutting-edge innovations in emergency medicine and critical care. Don't forget to subscribe, leave us a review, and share your thoughts on AI in healthcare. So long, Rebels. Thanks for listening, and we'll see you next time.